Hi, this is Dr. Mark Pohl, and this is a chalk talk on selected topics in non-neoplastic bone pathology. So in this chalk talk, we're going to go over the backdoor cut to non-neoplastic bone pathology. So number 1, fractures, will pass to number 2, osteonecrosis. Number 3, osteomyelitis, will set a back pick on number 5, Paget disease of bone, and the ball from osteoporosis will be passed to number 3, osteomyelitis, for 2 points. So as we always do, start off with some normal bone, just for comparison with the pathologic changes that we'll see later on. So the pink-red structures coursing through are the trabecular bone, and the arrows point out the lamellar architecture of the bone. So bone actually is highly organized, and that's what gives it its three-dimensional strength and support. Bone is also constantly in a state of remodeling. We don't see it, and it's imperceptible, but there's always a continuous breakdown and resorption of calcium from bone, and at the same time deposition of bone or of calcium into the bone to keep its strength. And so anytime that situation is perturbed, you get pathologic changes. Now in between the bone trabeculae itself is the bone marrow, and we'll talk a lot more about the constituents of bone marrow, which are the hematopoietic elements, in another course. But just realize that bone is composed of these two components. The marrow also contains fat as well, and the fat is a sort of supporting matrix for the hematopoietic cells to grow. So I'll start off with fractures because that's something everybody knows something about. You can categorize fractures by the completeness of the break, by the number of fragments that are produced as a result of the fracture, the relationship of the fracture to the overlying skin, and then also the underlying condition of the bone, whether the fracture occurred in normal or abnormal or pathologic bone. Simple fractures, also called closed fractures, are when the bone is fractured, and this is a complete fracture because the bone is completely fractured across and the overlying skin is intact. In contrast, compound or open fractures are where the bone actually penetrates the skin. Now on the right you see the green stick fracture, and that's an incomplete fracture, so the bone is incompletely fractured, and this is called a green stick fracture. Now when the bone is fractured across, again that's a complete fracture, but when the bone is actually fracture is fragmented, we call this comminuted fracture, and so obviously probably need to do some surgical repair to when there's a comminuted fracture, as you might imagine. There's another type of fracture called displaced, and this is where the ends of the bone are not aligned, and usually this requires some kind of surgical intervention too, rather than just setting the bone or immobilizing the bone. And finally, fractures can occur in abnormal or diseased bone, and we call these pathologic fractures. Now, most of the time, these probably occur in areas like osteoporosis, but you can see fractures that occur at sites of tumors. And so this is a radiographic image. You can see in the red circle the radiolucent mass that's at the end of the radial bone, and you can also see at the yellow arrow the fact that the bone is fractured there. So this is called a pathologic fracture, and it can occur in areas weakened by either tumor or by some kind of metabolic bone disease such as osteoporosis. One of the things about bone is that usually it can heal, and you can have almost complete restoration of the normal bone, especially in fractures in children. So this can appear radiographically sometimes as a mass, and we call this mass of fracture healing a callus, and I'll talk about that in a little bit. Fracture healing goes through a series of stages which are depicted in the image and in the text. But the 4 stages of fracture healing basically involve the initial formation of a hematoma around the site of fracture, and this is followed quickly by the influx of inflammatory cells into this area and the recruitment of bone-forming cells. The second stage is the soft callus, also called the procallus stage. This is where the initial repair consists of primarily collagen before osteoid and calcification is formed. When that process occurs, that's called the hard callus, and this is where you get the collagen being transformed into osteoid type bone, and this is calcified and is the leads to the next stage of remodeling, and this is kind of where the callus then is reformed or remodeled to match up with the normal bone adjacent to it. This is what this process looks like microscopically. The region of the fracture shows disrupted bone trabeculae, indicated by the square toward the bottom of the slide. The paler pink areas noted by the diamond here are the woven bone, which is formed in response to the injury, and is the initial way you can identify that new bone is forming. The asterisk identifies granulation tissue that forms after the development of the hematoma and on its way to forming the soft callus. Unfortunately, fracture healing can get off the tracks, and healing can be delayed or even prevented. As you might imagine from displaced or comminuted fractures, it takes longer to heal when the bone is displaced or if the fracture is comminuted, trying to knit together these additional pieces. And that's why frequently with these types of fractures, some kind of surgical intervention is undertaken to try to align the bone or to repair the fragments, and so it just takes longer to remodel these areas. Also, if there's inadequate immobilization, people don't stay off the fracture long enough, this can delay union, or you can have non-union, and this is called pseudoarthrosis. This is where the callus is not hardened or does not heal at all, and it appears and that those two bones then are mobile, and it can appear like a joint, so it's a pseudoarthrosis. And then there's also complications from the usual suspects: infection, if there's some kind of mineral or vitamin deficiencies that don't allow for proper mineralization of bone. Also systemic diseases, or if the bone is diseased itself. So this image just summarizes the factors that promote bone healing, which are good things, and the factors that delay bone healing or prevent bone healing at all. Next, I'll talk about osteoporosis. First, a couple terms to define. Osteopenia just means decreased bone mass. It may or may not be pathologic. Some bone loss occurs as a normal part of aging. Osteoporosis, however, is a pathologic term, and this is where osteopenia becomes severe enough that there's a significantly increased risk of fracture. Osteoporosis can either be localized or generalized. You can divide it into primary and secondary forms, although by far most cases are primary. Of the primary forms of osteoporosis, this can be, quote, senile or due to aging, or it can be postmenopausal in women. The clinical manifestations of osteoporosis vary according to what part of the skeleton is involved. So with involvement of the axial skeleton, you get formation of kyphosis, shortened stature, sometimes back pain or rib fractures. And with the appendicular skeleton in the box in the lower left, you get fractures that can be caused by minimal trauma. The common sites of these are fractures of the radial bone with even trivial falls or trauma, and also the hip bone of the femoral neck. There's a variety of predisposing factors to osteoporosis, which are outlined in this diagram. Now I'll talk about Paget disease of bone. This gentleman to the left may not be much of a looker, but he had a very distinguished career and really should be considered one of the co-founders of modern pathology. The other, of course, being Rudolf Virchow of Germany. Sir James Paget of England, amongst his many things, significantly discovered Trichinella spiralis as a cause of trichinosis, and he did this about the time he was a medical student. Again, like Laennec, kind of humbling. He also described Paget disease of bone, of course, as well as Paget disease of nipple. And both of these diseases still we refer to eponymically by his name to honor him. He revolutionized pathology in the mid to late 19th century by insisting on using the microscope in pathology. Before his time, pathology was really just gross pathology. So really a giant in pathology. All right. Yeah, I guess we could call Sir James Paget kind of the sixth man of this talk. But let's talk about Paget disease of bone, or sometimes referred to as osteitis deformans. I don't know anybody that refers to it like that, but you should know that term, I suppose, anyway. But Paget disease of bone, in contrast to osteoporosis, is a disease of increased bone mass. However, the bone formation is disordered, and the bone itself is structurally unsound and, of course, susceptible to fracture, which we call what? Right, pathologic fracture. Now, Paget disease of bone goes through a sequential series of steps. The osteolytic phase, in which the osteoclast activity is increased. There's a mixed phase in which there's both bone formation and osteoclastic activity breaking down bone. So you have this mixture of thinned osteopenic bone and then thickened new bone formation. And then finally, what we characteristically see clinically is the osteosclerotic phase, and this is where there's primarily continuing bone formation. And this is outlined in the readings. The upper panel of this just outlines, I think quite nicely, the pathophysiology behind Paget disease. That is, I should say, in the absence of some of the genetic changes that are found. However, and you're missing a little bit part of the picture with not having the kidney before. So you're not responsible for the details of this. It's just an outline to that succinctly shows what's going on pathophysiologically. I have a couple sections of microscopic Pagets coming up, but one interesting thing about the pathophysiology is that in electron micrographs of bone involved by Paget disease, there's these intranuclear collections of structures that are thought to be possibly virus. So a viral etiology has been proposed, although not proven, for at least some cases of Paget disease. So this is a microscopic image that shows the mixed phase where the down arrowhead is. You see the multinucleated osteoclasts resting in the little scalloped cavity there. The up arrowhead shows the osteoblasts lined up against the bone trabecula, and then the diamond shows the irregular cement lines that are formed in abnormal Paget bone. Just for comparison, again, the normal bone is up in the right-hand corner. The cement lines will be more obvious in the next image. So this is Paget bone compared to normal bone, both of them visualized under polarized light to kind of bring out these cement lines. You can see in Paget disease these irregular cement lines showing the abnormal disordered formation of the bone, and this leads to its weakness despite the mass of bone being increased itself. So you can compare that with the normal bone. So radiographically, there's a bunch of different sites here that are shown. Radiographically, the osteosclerotic lesions, as you might imagine, would appear radiodense or white on plain x-rays. And so here's just a few sites showing Paget involvement. The one inset here is actually a bone scan, and in the bone scan increased metabolic activity is noted by these black areas, and you can see increased metabolic activity in the pelvic area, in the upper right femur, and in the proximal humerus bone. It's important to remember, and this means that you should remember it, that one of the complications of Paget disease is the development of osteosarcoma, and that's what's depicted in the lower right-hand corner. Frequently, these patients also have bowed shins because of the increased mass of bone, and yet that bone is weakened and produces this bowing. There's a variety of other clinical manifestations that are outlined and depicted in this slide. Okay, osteomyelitis is inflammation, that is to say infection of bone. Although all types of organisms can cause and have been described in osteomyelitis, the most important organisms are pyogenic bacteria and then mycobacteria. There's 3 different routes to developing osteomyelitis. You can have a hematogenous spread to the bone. You may not think of bone as a very vascular organ, but actually bone is highly vascular, and that's because of the bone marrow and the intimate relationship of the development of hematopoietic tissue and its access to the circulation. You can have osteomyelitis develop as an extension of an infection from an adjacent site. And then finally, direct implantation of infection from either fractures or penetrating wounds, or finally iatrogenic, that is various hardware and other surgical interventions that interact with the bone. Clinical manifestations of hematogenous osteomyelitis include fever, because these patients are usually septic, and usually the bone shows the characteristics of inflammation, pain and tenderness, warmth, etc. This slide outlines some of the direct, that is non-hematogenous causes of osteomyelitis, from direct extension from adjacent structures, and this gives some examples of that, as well as some of the contributing or predisposing factors. One of the most common things we see in the pathology lab is osteomyelitis that's secondary to diabetic foot infections or chronic ulcers associated with diabetes. Finally, this slide shows some of the various ways that osteomyelitis can occur as a result of direct penetration of the bone and introduction of infection in that manner. This is a nice slide that summarizes some of the sources of infection, some of the most common organisms involved, and then finally the typical bones are involved. And as you might expect, the bones that are larger, that is, that have the most blood flow, are also the most common sites of infection. So the long bones and the vertebral column are the most common sites of infection. This slide outlines the pathogenesis of hematogenous osteomyelitis, and note that the infection is frequently localized to the metaphysis, where you have the richest termination of blood flow at the growth plate of growing bone, and then this is where the abscess develops and eventually forms a sequestrum. The surrounding bone around the sequestrum is the involucrum, two terms that you should be aware of. And then the final panel at the lower right-hand corner shows one of the complications in that osteomyelitis can form draining sinuses to the skin. This slide illustrates tuberculous osteomyelitis. This was described by Sir Percival Pott, another English physician from the 19th century, when it involves the spine. This is sometimes called Pott disease of the spine. And what happens is the granulomatous inflammation from TB infection it involves and destroys the vertebral body. This is from hematogenous dissemination of Mycobacterium infection. Typically, it is possible if it involves the thoracic spine that it could be direct extension from the lung, but usually this is a result of hematogenous spread. Microscopically in osteomyelitis, we see the marrow replaced by fibrosis and inflammation. The arrowhead points to a chronic inflammatory cell infiltrate. Notice that the bone trabeculae have become disorganized and the bone is necrotic. We don't see nuclei in there. That's shown by the square. Okay, the final topic is osteonecrosis, also known as avascular necrosis, and this is just a word that indicates ischemic infarct of the bone. So the image is that of a femoral head, a frequent site of osteonecrosis, and what's depicted in the triangle is the area of infarct, which forms a wedge shape, just like if you remember pulmonary infarcts in the lung. So the base of the infarct is right underneath the articular surface, and because the bone is necrotic, it falls away typically from the articular surface, forming this crevice. There's a variety of predisposing factors to osteonecrosis, which I won't read to you, but just know that most of the time, at least in adults, it just doesn't happen on its own. It does occur in a childhood form, which is idiopathic, although some of those are related to congenital hip dysplasia. It's a different mechanism or different predisposing form. And just like in other types of ischemic necrosis, you have the ghost outlines of tissue. In this case, the bone is preserved, however, there's no nuclei in the osteocytes. So you just have a bunch of empty lacunae, which are indicated by the up arrowhead. Also, the adjacent cartilage may break down and fragment, as we saw in the gross image, and this is indicated by the down arrow. The marrow is replaced by necrotic tissue and debris, and then eventually by fibrous tissue, which leads to dense fibrosis of the bone without revascularization. In the initial phase of the infarct, you see a hemorrhagic infarct because of collateral blood supply to the area, and the necrotic material is identified in this image by the diamond shape. So that ends the talk on my selected topics of non-neoplastic bone pathology. This is meant to complement the required readings, and I hope this helped illustrate some of the pathology from the readings. So, thank you. And congratulations, you scored a bucket on this chalk talk.